Assalamu alaikum class. Today we're going to study about the functions of nephron. We're going to continue our discussion about the functions of nephron. Up till now, we have discussed the first phase of urine formation, and that is glomerular filtration, and that is the initial function of the nephron. However, this filtrate is primarily in terms of its electrolyte concentrations same as plasma. Its osmolarity is also the same. There's difference in the protein concentration, and obviously cells are not present, but it is primarily the same. However, when it becomes urine, it becomes a different matter altogether. Its composition changes. As it passes from the Bowman's capsule and then reaches the papilla from where it will enter the pelvis and the ureters, it has changed from a simple filtrate into urine. And that happens because along the length of the nephron, certain processes of secretion and reabsorption take place, changing the constitution of the filtrate and making sure that a urine is formed. Nothing essential is lost, and everything that we need to get rid of to retain the homeostasis of the body, we get rid of those materials. So that is the topic for today, reabsorption and secretion functions of the nephron. You can see this simplified diagram, and it shows us that this is the afferent arteriole, and this is the efferent arteriole. And in between, your plasma undergoes filtration, and glomerular filtrate is formed. And this is present in the Bowman space, and Bowman space is connected to the lumen of proximal convoluted tubule. Then we have the loop of Henle, and then we have the thick ascending limb of loop of Henle, distal convoluted tubule, collecting ducts, and so forth and so on. And beyond the Bowman space, we have either reabsorption of certain solutes from the filtrate into the peritubular capillaries, or we have secretion of certain substances from the peritubular capillaries into the filtrate. And finally, there is final excretion of that particular substance. Now, if no absorption and no secretion takes place, then obviously the filtered load of that substance, in any substance in question, will be the same as the excretion rate, because nothing will change with regards to that particular substance. But if that substance is reabsorbed, then obviously its excretion would be reduced as compared to the filtration. The filtered load will be greater, excretion will be less. If that substance is not reabsorbed, but along the travel through the nephron, further more of that substance, a little more of that substance is secreted into the filtrate, then obviously the excretion rate will be more as compared to the filtration rate for that particular substance. One would normally assume that filtration is taking place at the glomerulus. So that is the amount of substance which will be excreted. If we are talking about a substance which is neither secreted by the tubules nor reabsorbed, then the same amount which has been filtered at the level of the glomerulus will appear in the urine. But suppose a little more is appearing in the urine than what was filtered. That means somewhere a little more of this substance is coming from. The substance is secreted in the urine. And therefore, if we want to determine the secreted load, we simply minus the filtered load from the excreted load. At the same time, what can happen is that the excreted load can be less as compared to the filtered load. Where did it go? Where did the substance in question go? It was probably reabsorbed, most definitely reabsorbed by the nephron. So if we want to calculate the reabsorption of a substance, then we will minus the excretion rate, because it will now be less than the filtered load. We will minus the excretion rate from the filtered load. Now, over here, we will first need to calculate the filtered load. We have been given the glomerular filtration rate, and we have been given the plasma concentration. We will simply multiply them. 120 multiplied by 400, we get 480 milligram per minute, which means that 480 milligram of glucose is being filtered per minute. How did we get this? simply multiplying the GFR with the plasma glucose concentration. Now we come to excretion rate. Like I said before, we multiply the flow or the rate with the concentration. So in case of excretion, 4 ml per minute was the urine rate, flow rate, which was mentioned in this question. And the urine concentration of glucose was 2,500 milligram per. So in this case, when we multiply the two, we get 100 milligram per minute. Now, this means that 100 milligram of sugar is being excreted in the urine per minute. But 480 milligram of sugar was being filtered per minute, and 100 milligram of sugar is being excreted per minute. So where is the rest of the sugar gone? Obviously, there are only two possibilities of something happening between the glomerular filtration and the urine excretion. Either secretion can take place. In that case, the urine excretion will be more than filtration. But on the other hand, reabsorption can take place. And in that case, excretion will be less as compared to glomerular filtration. And that is the explanation here. So we calculate reabsorption by 480 milligram per minute minus 100 milligram per minute. And we come to know that 380 milligram of glucose is being reabsorbed by the nephrons per minute. So this is a practical example which shows us how nephron handles something for glucose and a substance like glucose. And now, again, I want to discuss this with you. Now, the most common test which is done in, I'm going to be as bold as to say, in our setting as doctors, is the glucose test, is the test for glucose in urine, because diabetes is very common in our country. And as an immediate screening test, we tend to measure sugar in the urine. So, which means that we already understand that there is no sugar or undetected sugar in urine in case of healthy patients. And in case of diabetics, it will start appearing. And once that diabetic threshold is reached, the amount of sugar appearing in the urine will be proportional to the amount of sugar which is in the blood. And for that, we need to understand the concept of glucose titration curve, something called tubular maximum, and a concept of splay in these curves. It is also a very important question in physiology, called the tubular maximum curve. So this is very important. On the x-axis, we have plasma glucose concentration, 200, which is kind of the normal random, and then 400, 600, and 800 milligram per deciliter, plasma glucose concentration. On the y-axis, there is a different variable for three different curves, three different lines, which are drawn on this graph. For this green line, we are actually considering the glucose filtration on the y-axis. For this dotted blue line, we are considering reabsorption in milligram per minute. And this purple dashed line, for this purple dashed line, we will be considering excretion rate on the y-axis. And we're going to try to read this graph. So at around less than 200 milligram per deciliter, which would be any of yours, if random blood sugar, glucose, or post-meal sugar, plasma glucose levels. And you can see that this dashed curve is zero, is along the zero line, which means that none is secreted up till about 200 milligram per deciliter of sugar level in plasma. There is zero excretion in the urine. Then you can see that beyond about 210, the excretion rate in the urine starts rising. first slowly, and then after about 350 milligram per deciliter of blood sugar level, there is a steady increase in the rate of excretion. Now, on this side, we look at the filtration rate, this green line, and it's a fairly simple, straightforward graph. There is a direct proportionality between filtration and plasma glucose levels at all values. At any given value, there is direct proportionality. So from 0 milligram per deciliter to 800 milligram per deciliter, there is a uniform rise in glucose filtration as there is a rise in plasma glucose levels. जितना भी प्लाज्मा में के जितना भी ग्लोमेरुलस को प्रेजेंट होगा ग्लूकोज उसको फ्रीली फिल्टर करता रहेगा. So this line is a straight line. And excretion is, there is no excretion till about 200, 210 milligram per deciliter, although filtration is taking place. And after 350 milligram of deciliter of sugar level, excretion then becomes proportional to filtration. After this 350, before between 350 and this 250, perhaps 210, 220, 250, this there is a gradual increase in urine concentration of glucose. And after that, there's a steady increase matching the filtration rate. There's a direct proportionality between filtration and excretion. And reabsorption. And we can see that in the normal levels of plasma glucose in non-diabetics, so up till 220 millimeter of mercury, suppose here, there is again a steady rise in reabsorption. As much is filtered, the same amount is reabsorbed. So you can see this dotted line actually superimposing itself on the green line, which means all that is filtered is reabsorbed until this threshold value. At this threshold value is the same value at which we start urine, at which glucose starts appearing in the urine. And we can see that at that point, our reabsorption rate starts to fall. It's no longer rising. It's like before. Its rise has become slow. And eventually, beyond about 350 milligram per deciliter, the same amount is reabsorbed. No matter how much plasma glucose concentration increases, only the same amount of glucose will be reabsorbed. So what will happen to this extra glucose which is being filtered? It starts appearing in the urine. So this point, about 220 milligram per deciliter, is called threshold value. It is at this value that glucose first starts appearing in urine. And it corresponds to the point when reabsorption rates start to decrease. And we'll discuss shortly why the reabsorption rate has started to decrease in its rising. And then we see that about at 350, which is the second critical point on this graph, excretion becomes freely associated with filtration, and reabsorption has become fixed. Between these 2 points on the excretion curve or the excretion line, there is you can see a transition phase. This is called splay. Similarly, on the reabsorption curve, the straight line becomes a steady line, and this transition period between threshold and 350 milligram per deciliter is again splay for the reabsorption curve. At molecular level, what is happening? So at molecular level, in normal glucose physiology of a patient with no symptoms of diabetes or pre-diabetes, what will happen is glucose will be filtered freely since it can pass through the glomerulus filtration barrier. And in the proximal convoluted tubule, there are lots of glucose transporters present which easily take up the glucose, so that by the time glucose reaches the latter part of nephron, there is nothing there and no glucose will appear in the urine, thanks to the transporters in the proximal convoluted tubule. However, though abundant, they are limited. though abundant, they are limited. So when the amount of glucose passes a certain level in the blood, all of it will still be filtered, but the excess when it will reach the proximal convoluted tubule, it will engage all the transport proteins. And still some glucose will be left, which will pass on further. This is called saturation. Initially, this saturation takes place gradually. And that is the explanation for the splay, that this saturation will take place gradually. And this figure of 350 milligram per deciliter, where carriers are totally saturated, is called the transport maximum. Because at this point, the maximum capacity of reabsorption has been achieved. It's called transport maximum. Just take place of PSL and everything. So they have these buses which are picking the participants from certain spots. And suppose those buses have a capacity of 100 passengers. And lots of people gathered at those bus stops. They want reabsorbed and taken to the critical. Now, if the number of people who are arriving at those bus stops is less than 100 at a time, then all of them will be taken to the stadium. Reabsorption.
Right, which is in normal condition, jo ke normal hai.
Exactly, and none of them will be excreted. Or excreted can be compared here to them being disappointed and going back home. But if more of them show up, 150 show up, the bus capacity is still just 100. So 50 of them, of that lot, of that crowd will have to go back home. Or in this example, that will be equivalent to being excreted. Point about clearance of the titration curve for PAH. Now, glucose was an example of a substance which was reabsorbed from the nephron. And para-aminohippuric acid, which is another chemical we use to measure the clearance for renal blood flow calculations. So this para-aminohippuric acid is something which is secreted by the tubules into the filtrate. So the amount of PAH which will appear in the urine will be greater than the amount of PAH which is filtered. And this is the titration curve for PAH. Over here, you can see that the amount filtered is again shown by a green line. It is at exact 45-degree angle, which means as much change takes place in x-axis and correspondingly the same amount of change takes place in the y-axis. This is direct proportionality. As much is filtered, all that amount will be excreted. So as much appears in the plasma, all of that will be filtered. Now again, we see that the secretion is also limited here. Okay. Now, you can see that again, there are receptors which are secreting your PAH into the filtrate. And however, they also, what you have to notice here is that this secretion is also taking place from the blood. Now, some of the PAH was filtered at the glomerulus. Let me just, I want to explain this face to face. Now, PAH was partly filtered at the glomerulus, right? But some of it wasn't 100% filtered. Some of it then went into the efferent arteriole, into the peritubular capillaries, which are surrounding the tubules. And from there, PAH is secreted by transporters into the tubules now. So it is still being secreted from the blood into the tubular lumen. And for this purpose, they also require transporters. And by the same argument we used above, all transporters have a certain capacity to bind a certain number of their transported molecules. So as the concentration of PAH in the blood of peritubular capillaries will increase, secretion rate will increase, but up till a point when those secretion transporters are saturated. And at that point, again, your plateau will be reached. Since because of being secreted additionally from the peritubular capillaries, the clearance of PAH is considered to represent represent blood flow of the kidney very effectively, most effectively. So just reviewing a bit about what we meant by clearance. Clearance was urine concentration of a substance multiplied by urine flow divided by the plasma concentration of that substance. And remember, we discussed that inulin was an ideal substance to measure GFR, just the filtration bit, because it is neither secreted nor reabsorbed. And although creatinine is secreted, but we underestimate its measurement at the level of testing of the urine. And those two errors cancel each other out. In case of PAH, it is secreted. So what is not filtered from the glomerular capillaries and appears in the peritubular capillaries is then secreted from the peritubular capillaries into the tubule, and very little appears in the veins. So that is why the clearance of PAH is considered as representing renal plasma flow. And how do we convert plasma flow into blood flow? By simply applying this formula, dividing the renal plasma flow by 1 minus hematocrit. So this was our discussion for today. We discussed the secretion and reabsorption functions of the nephron, and we discussed two important concepts: filtration rate and excretion rate, and what happens in between, that there can be reabsorption and there can be secretion and how we can calculate them. We talked about the concept of transport maximum for two types of molecules. One, glucose, which is reabsorbed, and one, para-aminohippuric acid, which is secreted. And finally, we discussed, or rather reviewed, how PAH clearance can measure renal blood flow.